Describe the surgical technique. Good morning, everybody, and welcome to the Sunday morning trauma class, trauma master class. And we have today with us Dr. Wasudeo Gadegone, who is going to speak on suprapatellar nailing of tibia fractures, and he will describe the surgical technique and various tips and tricks in it. After the lecture is over, we are going to have a master class on the WhatsApp group. So you can watch this lecture and then note your questions and queries, and you can post it on the WhatsApp group. Dr. Gadegone will be available on the group to answer your queries. So over to you, sir. We are eager to hear from you. Welcome.
Thank you, Ashok, giving me the opportunity to deliver a lecture on surgical technique on suprapatellar nailing of tibial fractures. So this is a new nail that is known as a Gadegone Pandya suprapatellar nail. This is designed by me and Pandya of a Yogeshwar implant to describe a simple method for suprapatellar nailing. A step-by-step run through the surgical technique is the aim of this presentation. The tibial fracture fixation options, the standard for diphyseal fracture intramedullary nail, but challenges of nailing in proximal and distal tibia. The challenges of nailing in proximal distal tibia are many, but they are mainly wide medullary space, small unstable fragment. Just passing a nail does not reduce the fracture as in the sharp fracture, and often it is associated with intra-articular extensions. So differences between the proximal and distal tibia: a quadriceps is the deforming force, whereas in the distal tibia, the fibula is the deforming force. So differences between proximal tibia and distal tibia again. Entry point is very crucial, and that should be the perfect for the placement of the proximal tibial nail. And in the distal tibia, central position of the nail is important to avoid the malposition and malalignment. So nailing in hyperflexion of the knee, most popular method for the diphyseal fractures of the tibia, but maintenance of reduction and imaging is very difficult in a proximal tibial fractures. So classical infrapatellar nailing with the knee flex to 90-degree leads to predictable deformities, flexion or apex anterior, posterior translation of distal fragment, and valgus deformity. And therefore, the nailing in proximal tibia is very unpopular, and infrapatellar nailing use malalignment is the rule in near about 63% of the cases. Therefore, ultimate result in a proximal or distal tibia, the malalignment leads to instability and ultimately the failure of the implant and non. So what is the solution then? Solution number one is a suprapatellar approach in a semi-extended position to overcome the deformity and to overcome the forces of the quadriceps tendon. Now, this is the one of the best article, a suprapatellar nailing of tibial fracture indications and technique. This is published in Injury 2016 February. The tension of the quadriceps tendon causes a typical apex anterior angulation of the proximal fragment. The suprapatellar approach improves reduction of the fracture and reduces the occurrence of malalignment during IM nailing of extra-articular proximal tibial fracture. The knee is positioned to 20 degrees of flexion to neutralize the traction forces secondary to the quadriceps muscle, thus preventing an apex anterior angulation of the proximal fragment. In addition, advantage of this technique is it is mostly a closed technique as the proximal tibial fracture often they are associated with the soft tissue injuries. Solution number two is a use an appropriate nail. Now it can be done in a proximal as well in the distal tibial fractures. It requires additional planning, special instrument, advanced technique, and special nail with the multi-lock systems. So maintaining this curve proximal to the fracture will minimize the deforming force. Therefore, this is the solution number three. We require a high bend nail in a proximal. Another solution to improve the malalignment after passing the nail or to guide the guide wire, you need to have a blocking screws. This is a blocking screw or a minimal invasive adjunct to prevent valgus and flexion deformities. And also they are called as a polar screw because the screw guided the nail. To address the instability in the fracture and distal debate is well described by Critic et al. And this is a classical picture. You can see how to put the polar screws on the valgus side and on the flex side. That will guide and correct the deformity of the proximal tibia. Now, suprapatellar nailing, the indications are proximal and distal tibial fracture, segmental fracture, poor skin condition over the patellar tendon, and all indications of conventional infrapatellar nailing. This is the operative technique. Confirm the site of the injury. Measure the nail length on the normal limb. Beginner, they are advised to apply a tourniquet or otherwise tourniquet is not that necessary. This is the position, most popular position, bolster under the knee to maintain the 15 to 20 degree of flexion, bolster under the hip to neutralize the external rotation, and whale leg is flexed, externally rotated and positioned to allow free C-arm movements. This is the standard position which is required for the suprapatellar nail. Now these are the nails available. They are long nail and short nail. Now mostly we use a long nail. Short nails are required only when there is a cross deformity and pushing the nail inside the diaphysis may cause a translation of the nail. Therefore, you can also use a short nail which is available, and jig which is there, it is different than the infrapatellar nailing because it requires a jig and long protective sleeve to pass underneath the patella. And these are all other inventories required in the suprapatellar nailing that are required in the normal nailing process. Now, specification of this suprapatellar nail, proximal diameter is 13 mm, distal diameter is 8, 9 to 10 mm, two mediolateral and two oblique bolts at 60 and 45 degree, 5 mm locking bolt for proximal and 4 mm for distal, 10 degree of horizontal bend at 60 mm from the top, end clamp to prevent tissue ingrowth. So this is the nail assembly. You can see you have to assemble the nail like this, and you can first check the this assembly because it is very important. Otherwise, you may have a mismatching of the nail. So intramedullary nailing, reduction before the nailing, ream with the fracture reduced, maintain the reduction throughout the case, multi-locking proximal and not always easy. The procedure is very, we have to begin with the procedure, surface marking of the patella as well as the tendon and the suprapatellar region. I inflate usually near about 30 degree, 30 cc of air with the saline so that I can translocate the patella very easily. This is how it is. The inflation of the uh, knee joint. Then upper tibial pin for better manipulation of the proximal fragment to direct trajectory into the medullary canal. I pass near about the Stillman pin and that is converted and it acts as a polar pin and that is may be converted into a, it is replaced by screw after the procedure is over. And this is the pin which directs because it should if you don't put this pin, what will happen is that the guide wire will go posteriorly. So to keep the guide wire anteriorly, we have to pass a Stillman pin or we can also pass a polar screw. Now after this, in a distal tibial fracture, for proximal fracture, you have to put the upper tibial pin. For distal tibial fracture, you can for better manipulation this pin is passed. That is the calcaneal pin is passed, so that it will helps in the manipulation as well as in the reduction. Now reduction devices to be used: percutaneous clamp. Most important is the percutaneous clamps. Percutaneous assisted reduction, close locking nail is if you have to reduce it by clamp, and that clamp had to be kept till the nail is inside and you have done the locking. This is the most important thing we have to remember. Now this is the incision, how to proceed. This is after inflation of the joint. Give a small incision over the suprapatellar region near about 2 centimeter in length, and then with the artery forceps, you go enter inside an insertion of the, this is the trocar, and this is insert the trocar inside the joint through the trochlear, and it will go at the upper end of the tibia. Now next afterward this incision, trocar insertion, and then you pass the guide wire sleeve, so that you can pass the guide wire in the proximal tibia. This is the Stillman pin. You are passing the guide wire exactly on the this lateral tibial tubercle, medial to the lateral tubercle, and probably this is the best entry point from the tibial spine. It is near about 6 to 9 millimeter. Now this is how it is. You can see again that the trocar, it is for just to give the impression for the guide wire, and guide wire is negotiated. After negotiating the guide wire, exchange of the trocar with this guide wire sleeve, and guide wire is passed. Now this is the guide wire. This is the widening of the track is done first, then the sleeve, and then the guide wire is passed, and this is the Stillman pin is passed, which will guide the guide wire in the medullary canal. Now after this guide wire insertion, now we have to pass the guide wire insertion through the fracture side. You can see this is the guide wire is inserted through the fracture side. Sometime there is one pin is needed on the medial or on the lateral side to guide the guide wire. So that is known as antero. This is antero-posterior pin, mostly on the lateral side to prevent the valgus deformity, and it acts as a polar screw also, or you can pass giving a small incision and pass the polar screw. So the two from the mediolateral from the posterior side and antero-posterior from the medial or lateral side, depends on where the guide wire is going. Now after this reaming of the canal, this is the proximal reaming, and after proximal reaming, you exchange the guide wire, and you exchange the guide wire. Long guide wire is passed, and then you can do a reaming of the isthmus till you go to the IGL place of the distal tibia. Now this is the most important step. This you can see here. This is the clamps which will keep the fracture reduced. That is the most important thing. And this is the reaming of the canal. And we have to ream. If you want to pass a nail up near about 10 mm, then reaming is done of 11 mm. So now this is the introduction of the nail. After reaming this, you can see with the, you have to glide the nail. It's not necessary to hammer, because otherwise there will be a small proximal fragment splintering may occur. Now after this, the placement of the nail, how to judge it, because it is the blind procedure. So there is a hole is in this assembly that will be corresponding with the upper tibia, and that is the corresponding with the upper tibia. We have to find out this. This is corresponding with the upper tibia, so that our nail, our screw will near about 15 millimeter into this guide, this K wire. So after this polar wire is after these are the all screws are placed. If necessary, this polar wire is replaced. If necessary, you want a better stability, then this polar wire is replaced by a regular 4.9 mm screw, or you can use a 3.9 mm screw. So depends on, if there is a more spaces there, then you can use a 4.9. Otherwise, you can use a 3.9 screw. Now this is the proximal locking. Now there is a tip first. One, before going to the mediolateral screw, it is better to pass first a oblique screw that stabilizes the nail, as well as this is the oblique screw at 60 degree. It stabilizes the nail and the whole assembly, so that the mediolateral screw, there goes very easily the two mediolateral screw, one oblique screw, and then after that you do a distal locking. Now here in the distal tibia fracture, it is most important to have in the center position. But in the proximal tibia, we have to reduce the fracture, see the reduction, and wherever there is a nail, that place we have to do the distal locking. So CR positioning and distal locking is easy in this position. You can see here, this is the diaphyseal fracture, proximal upper one third, you can say, and there are 3 screws are passed near about. You can pass it 2 screw also. Here there are 4 screws are passed, 2 mediolateral, 2 oblique screw, and 1 polar screw. And you can see here how the easy position of the CR. You can see the from toes to the thigh. You can easily see the whole limb because of the position AP and lateral. So the handling of this CR and the reduction loss is not much in this position, because we don't handle this. And before the end of the operation, it is important to flush the knee joint carefully of all blood and debris, and you can keep a drain if it is required. I don't advise to keep the drain, because I have not done it, but it is described that drain should be kept in the knee joint. So this is the extreme proximal tibial fracture. This is the example. A suprapatellar approach. You can see a very small fragment is there. It is an absolute indication. You can see here the plating. It can be managed. You can use a compression screw and then neutralizing plate. But the patient was in a hurry. There was a compound grade 1 fracture. Soft tissue was not good. So I have tried to do it by bypassing everything, so that the reduction was done properly. And then this was a healthy area. Suprapatellar approach. This was the nail insertion. So, and stages of surgery. This is the clamping. then passing the guide wire, and you can see passing the guide wire into diaphysis, direction, and ultimately polar screw, apex anterior fragment fixation, reaming, and you can see here how the beautifully the reduction is there, and you can see this is the 1 year follow-up of this case, complete healing of the fracture, full function, and you can do it. This is a short fungible tibial suprapatellar nail. And this is also another example, a very proximal fracture, only near about 5 centimeter or 6 centimeter part is there, and the nailing was done. There was some malalignment is there, but it has compensated. This is acceptable, and the fracture has completely healed. Another example, you can see a proximal tibial fracture. This is fixed with the nail, perfect anatomical restoration. This is the polar screw posteriorly replaced in one pin, and ultimately you can see there are 4 screws. There was also a posterior tibial fracture. The posterior that was also this was after changing the position that was also fixed. So another a segmental fracture of the tibia and fibula after roadside accident, soft tissue compromise. We waited for near about 8 days. This fixation is done by a suprapatellar nail. You can see here the polar screw is here, and this is how fixation was done. In some distraction here because of the large size of nail, we could not avoid that. Union after dynamization and full function of this patient after 3 years follow. It is very, you can see here, perfect anatomical restoration and function of the patient. Another example, extreme proximal tibial fracture, short proximal tibial nail, but nowadays I don't use this nail. I use a long nail, but previously I used to do this thing. This was a very short fragment, classical indication of the plating, I don't deny, did by this nailing, and you can see here after 1 year follow, perfect union of this patient. Now for the technique for a distal tibial fracture, same the semi-extended position, and you can see that you use it for proximal tibial fracture, distal locking option. There are 3 locking or 4 locking systems, and these are all 2 mediolateral, 1 AP and 1 oblique. This is the specification and current indication for nailing. You can see here. This is the third 22 mm. Means extra-articular fracture, subtibial fracture within 30 mm of the plafond can be treated by this technique. This also can be treated by the intrapatellar approach, but in a suprapatellar approach, we need not change the position of the leg after reduction. You just pass the nail. CR imaging is very easy, and by calcaneal traction, you give a constant traction so that the limb is in proper perfect position. So need a biplanar exam, CT scan, current length and size of the nail, patient selection, work for soft tissue, and if required, spanning external fixation. This is the semi-extended position, same position, but here only one thing is required, a calcaneum peel or better manipulation of a distal fragment. So now this is one of the example, intra-articular extension fracture. You can see here, this is the intra-articular extension fracture. It is fixed with the screw first, and then what has happened? Fibula is a deforming force, may require the fixation of the fibula by nail or plate, improves the stability of the bone implant complex in a supramalleolar fracture, and there is enough evidence that if there is a displacement of the fractures of the fibula within 8 centimeter, that would be fixed along with the nail. And then this is how it is, a percutaneous reduction of the fracture with clamps. Intra-articular fracture is fixed. This is the clamp, and the guide wire is passed. Manipulation made to guide wire in the center. And if it is not there, then you can use a polar screw to guide the guide wire. Fibular fixation by nail or plate. I use a screw intramural nail for fixation of the fibula in a transverse and oblique fracture, in a comminuted fracture. I prefer hip plating. So this is how it is. You can see here how the fixation of fibula is done by screwing intramedullary nail, and this is the entry point. And then after entry point, we have to negotiate the nail slowly, and you can see under C-arm, and the nail is negotiated into fibula first, and then screwing is done. So final tightening is done. This is mostly a percutaneous technique, and you can see here how beautifully and nicely the fibula is fixed. So this is how it is. So I do it mostly. I don't deny that this fibula fixation by plate is a most convenient method and most accepted method, but mostly I do it by percutaneous fixation and scar of just 1 centimeter, no soft tissue damage, because it avoids already damaged tissue. Reaming done till the physial scar, that is the most important thing in a distal tibial fracture, because our lower screw will come within near about 11 mm. So therefore it must go. There is the screw. This is the last distal screw, oblique screw, and medial lateral screw. In difficulty in centralization of the reamer and nail. This is now is the guide wire. It is in the center, but there is no reduction. We must have a clamp here. And then in difficulty, it is better to put a polar screw so it narrows the canal as well as it guides the nail as well as the reamer. And so blocking screw is most important in both proximal as well as in the distal tibial fracture. Distal screw insertion. If there is a proximal tibial fracture, 2 screws are enough. One is anteromedial, this mediolateral and antero-posterior. And if you have a distal tibial fracture, it is better to fix with 3 to 4 screws. So a case of a distal 1/3 shaft fracture, you can see here, it's a small place is available here, fibula is fracture, it's a comminuted fracture, plating as an indication, you can do it, but there was a soft tissue problem. I did it, comminuted with soft tissue compromise, and with the same principle of this clamping, and ultimately this fracture completely restored the anatomy. This is probably a 2 months follow-up of these fractures. So advantages of this method is simple access to entry point at proximal tibia by suprapatellar approach, facilitated fracture reduction, avoids patellar tendon. The extended position of the lower limb allows for easier fluoroscopic imaging. Cartilage damage is mostly theoretical possibility, and recent literature and arthroscopic finding, and with improved design of the nail and the uh, the sleeves, now the cartilage damage is very minimum after the suprapatellar nail. Now these are the recent articles. There is 2018 article comparison of suprapatellar and intrapatellar nailing, tibial fracture, a systemic review and meta-analysis. What is their conclusion? Suprapatellar intramedullary nailing could significantly reduce total blood loss, postoperative knee pain, and thoracoscopic time compared to the intrapatellar approach. Additionally, it was associated with an improved Lysol knee score. High quality RCT were still required for further investigation. And most important is the coronal placement of the nail is best in the suprapatellar approach. Another is article in 2018, suprapatellar nailing in tibial fracture, evaluation of clinical and radiological result. And their conclusion, approach allows for an easy reduction of the challenging fractures of the proximal third diphyseal fracture of the tibia and multiple fracture of the tibia, and facilitate an easy check of the axial position of the extremity. The functional result of the knee joints are comparable to those achieved with the intrapatellar nailing technique. And now there is another important in intrapatellar approach. There is a tendency to injury to the suprapatellar nerve ending, which irritates mostly and it is very discomfort. this uncomfortable to the patient, which is avoided in this case. And in the proximal tibia, often there is an injury near the tibial tuberosity that is also avoided. So in take-home message, proximal and distal tibial fracture may result in a reduction that is unacceptable to the both surgeon and to the patient because of the non-availability of the suprapatellar approach nails, and also the method was not described previously with older designs. With careful attention to details, this fracture can be managed with the intramedullary nail and mostly by closed method, whereas plating is an open method of already a soft tissue compromised patient. Mostly the blade infection chances are more, and it is described about a 32% in literature recently. So suprapatellar nailing scores for the intraoperative nailing on many aspects. Mainly the only the objection is here. We are going through the knee joint, so there are some theoretical chances of infection and cartilage damage, but with the due precaution, cartilage damage is avoided because we get now a good quality of sleeves which they slide underneath the trochlea, and second with careful precaution, rate of infection which is there, it can be the infection is a iatrogenic complication which can be dealt with proper surgical technique. So thank you very much, Ashok Shah, and all participants on this Sunday trauma class. And if any questions, I will be happy to answer throughout the day. Thank you very much.
Thank you very much, sir.